So welcome everybody. We are absolutely thrilled that you have taken the time out of your evening to join us for this panel for newly diagnosed gynecologic cancer patients. My name is Rachel Justice, and I am one of the co-leaders of the Woman to Woman program at Mount Sinai in New York City. And we are absolutely thrilled that this event is actually now a 5-way collaboration. So it is being put on by 5 wonderful organizations who I will name. So Ashley Schneider is with WOCA in Wisconsin, the Wisconsin Ovarian Cancer Alliance. Ruth Ann Ornstein is at Yale, and it's Discovery for Cure, to Cure. Okay.
To Cure, Discovery to Cure, part of Yale University.
Part of the Yale University program. She's up in Connecticut. We also, for the first time joining us, we have the Clarity Foundation. We are absolutely thrilled to have you represented here. It's a great organization. And we also have Teal, Tell Every Amazing Lady. So again, we are so excited to join with our fellow organizations who are doing whatever we possibly can to support gynecologic cancer patients on the cancer journey. We are all here to help. We hope that this evening provides not just information, but a sense of community, because that's really what this is all about. It's to show you that you are not alone. You are part of a community. You are part of a supportive community. We are all here for you. Your fellow patients and survivors have got your back. They are here for whatever you might need. So please listen, chime in. There's going to be quite a chunk of time at the end for audience participation. Again, we're going to ask that you hold your questions until the end. We have 3 wonderful speakers, and you can put your questions in the chat. You can use the hand raising feature if you'd like, or you can do the old-fashioned wave and just get someone's attention, because we will be monitoring. We will do our best to make sure everyone's questions are answered. So that is my official intro, and I'm thrilled to just launch right in to our topic. So we are really lucky to have Dr. Erin Stevens here with us this evening. She is a place that we all wish that we would be. She's actually doing this while she is away, so we extra appreciate you taking the time to do this. Dr. Erin Stevens is the board-certified gynecologic oncologist with Privia Health in Green Bay, Wisconsin. She graduated from New York Medical College in 2005 and then completed her residency in obstetrics and gynecology at Stony Brook University Medical Center on Long Island, and her fellowship in gynecologic oncology at SUNY Downstate in Brooklyn, New York. In September of 2018, she joined Privia Health to take over the gynecologic oncology program and continue to provide excellent comprehensive care to patients with gynecologic cancers in Green Bay. She serves on the ACS Wisconsin State Leadership Board, participated in ACS Team Determination for the New York City Marathon in 2019, and holds numerous leadership roles within Privia Health and St. Vincent's Cancer Center. So Dr. Stevens, we feel so lucky that you are willing to join us and share your expertise, share your passion, share your knowledge, and share your experience with us. So thank you so much.
Thank you all. So I'm going to work on sharing my screen because will fully admit I am never good at this when I have to do it. Everybody see my presentation? Fabulous. Let me make my little chat window small. Okay, so my part in this conversation today is going to be, now what you need to know after you've been diagnosed with a gynecologic cancer. First, we need to start and talk a little bit about cancer itself. So we know that likely this year, nearly 117,000 women will be diagnosed with a gynecologic cancer. At this point, we have millions of gynecologic cancer survivors in the United States. But we need to kind of spend a little time to talk about what cancer is before you sit down at the gynecologic oncologist's office. So what is cancer? Cancer is simply a cell in our body that forgot how to die. It's a normal cell that undergoes a dividing process that makes a mistake along the way. And that mistake allows it to continue to grow and then spread unchecked. So we go from normal cells that undergo this oncogenic event that lead to cancer cells. So cancer isn't just one thing. Cancer is a billion different mistakes in a million different places. And we are getting much better at defining exactly those mistakes and how that can play a role in our treatment. So while we're going to talk in big global terms today about different types of GYN cancers like endometrial cancer and ovarian cancer, know that we are getting more and more specific to treatments based on more information we know about the actual cancer mistakes themselves that are happening in your cancer cells. So when it comes to gynecologic cancers, it comes from the gynecologic system. So this is your uterus, your fallopian tubes, your ovaries, the cervix, the vagina, the vulva, which is the skin on the outside of the genitalia, as well as a rare cancer called gestational trophoblastic disease. So these are the cancers that we talk about when we're specifically talking about the gynecologic cancers, the below the belt cancers. Now, breast cancer has done a fabulous job about raising awareness and getting people comfortable talking about their breasts and what can happen there. Gynecologic cancers, we're still in that struggle of people feeling uncomfortable about talking about getting diagnosed with a gynecologic cancer. My mother is a uterine cancer survivor. She had stage 2 endometrial cancer a couple of years ago. And even with a daughter that's a GYN oncologist, my mother doesn't like to tell people that she had uterine cancer because she feels uncomfortable, because it's part of that reproductive system that we really just haven't taken that stigma out of. So one of the things that requires a little bit of practice is to get comfortable with these organs just in general. As you're talking to your physician. I've had many patients over the years as I talk about the vagina a lot, whether we're doing surgery to remove the uterus and the vagina healing after, that they're just uncomfortable with the word vagina. But it's important to be empowered by these words because this is part of your body and this is part of your cancer and the journey that you're on. So it's important to be able to name the structures accordingly. Now, there are a lot of words when we get into cancer themselves, and people struggle with what these words end up meaning because it's really complicated. It's a word salad, and especially nowadays that we release results in real time. So you have the opportunity to read your pathology report, your CAT scan report, your doctor's notes, and that's going to include a lot of words that may look scarier than they actually are. So some of the words and terminology you may see and you may hear from your doctor as you're going through treatment. One of the common words that ends up on the radiology reports is neoplasm. Neoplasm simply means a new growth. It does not mean that there's a cancer there. A functional cyst on the ovary is a neoplasm. It's a new growth that's going to go away on its own. So don't equate seeing the word neoplasm on a report to meaning that something has changed about your cancer. It's just kind of a catch-all word for something that may not typically be there, but isn't necessarily cancer or not. You'll also hear us as physicians talk about things like tumors or see that on reports. And tumors themselves are just, again, new growths, neoplasms, that could be benign or malignant. And that also gets complicated. Benign, you can have a benign tumor, which is a non-cancerous growth. You can have a malignant tumor, which is a cancerous growth. And so most of you today are here because you've been diagnosed with a gynecologic cancer already. And so we're in the world of malignancy. But as you get scans and imaging and as you go through your course of treatment, benign tumors may also show up on your scans along the way. So it's important to know that some of these words, you're going to see them, but they may not necessarily mean bad things as we go. The other word we often talk about is metastasis, which is spread from the original location. And patients will ask me a lot, well, did my cancer spread? Now, depending on the type of cancer you have, that could be encompassed in the stage as we talk about staging of your cancer. Gynecologic cancers very commonly spread within the abdomen itself, which is the area from your diaphragm right below your chest down to your pelvis. And that can be in the lymph nodes, that can be within the abdominal cavity itself. And all those are technically metastasis, but those are very treatable metastasis and things that we can manage with both surgery and treatment. So metastasis is a word that you'll see, and it's something that you should talk to your physician about. What does that actually mean for you? Is that something that's going to change your treatment, or is that something that's actually expected with the type of cancer that you have? The next phase, once you've been diagnosed with a gynecologic cancer, there may be a workup that happens at the beginning. You may have just had an endometrial or cervical biopsy in your gynecologist's office to get the diagnosis of cancer. Or you may have had a CAT scan or an ultrasound that showed something suspicious within the abdominal cavity concerning for an ovarian cancer. So you may have imaging tests. You may get an ultrasound, you may get a CAT scan, okay? You probably will not get a PET scan, though you may, because cervical cancer and vulvar cancers we use PET scans for. But those aren't as helpful for our uterine cancers because uterine cancers are often more slow growing, and often they won't show anything on a PET scan. So it's important to talk to your doctor about what imaging tests are actually important for your cancer and what might you hear about but isn't something that actually is beneficial for the type of gynecologic cancer that you have. Then there's blood work that may need to be done. So CA-125 is commonly one of the blood tests we talk about with ovarian cancer. It's sometimes used for some types of uterine cancer, but when it comes to cancers like cervical cancer and vulvar cancer, there isn't a specific blood test to tell about your cancer status, whether it's being treated or in remission or whether it's recurred. So asking your doctor, what blood work should I have? What blood work is beneficial as we go through treatment? Or is there blood work that we're just checking, like your blood count, as part of your treatment, but doesn't tell us anything about your cancer? What we're looking for, all of us, is a blood test to tell whether or not our cancer is there. And there are plenty of research studies going on about that right now, but we're not there yet for that blood test to talk about your cancer and whether or not it's there. But no, that's one of the places we're spending a lot of research. There's also tumor-specific testing. So you may have your biopsy sent off for additional testing to see what mistakes or genetic mutations exist within your tumor that allow us to actually give you specific treatments based on that. So asking whether or not your tumor should be sent for tumor-specific testing. And then again, as I talked about, biopsies are often part of the initial diagnosis and workup. Now, whenever it comes to cancer, there's two things that we always want to know when it comes to our cancers: the stage of the cancer and the grade of our cancer. So staging, you often hear about in stage 1, 2, 3, or 4. And that's often combined with some letters and occasionally some numbers. So you may see something like 3C little I, or 3C2, or 1A1. And that just gives us the information about how far the cancer, where the cancer started and whether it spread to other places. So staging also is supposed to, but not always, be predictive of prognosis. Stage 1 cancers often have a 90% or more 5-year survival. Now, it's important to know we only measure up to 5 years in cancer, okay? 5 years, if your cancer doesn't come back, we consider that a cure. So we don't have measurements very often extending past 5 years. So we measure everything in 5 years. That doesn't mean we only expect you to live 5 years. But stage 1 cancers often have a 90% or higher 5-year survival. Stage 2, around a 70%. Stage 3, around a 50%. And stage 4, around a 30%. Now, anytime we talk about statistics like that, it's not individualized. That's what the global population is. And so it's really hard to say where you'll fall in those statistics, but it's important to open that conversation with your doctor. Grade is what the cancer looks like under the microscope. And that's often done as grade 1, 2, or 3, or well differentiated, moderately differentiated, or poorly differentiated. And that just, again, is what the cells look like under the microscope. So very commonly, patients diagnosed with endometrial cancer will be told that they have a grade 1 cancer. And when they come and have their first opportunity to talk to a gynecologic oncologist, they hear stage with that. And they said, well, I was told I have a stage 1 cancer. But you've got a grade 1 cancer. Stage comes in that type of cancer from surgery. So it's important that both of these are components of everybody's cancer. And it's a good question to ask your doctor, what stage am I? What grade is this tumor? And what does that mean for me? Now, treatments for gynecologic cancers vary. They vary based on where your cancer started, varies based on the stage and the grade information that we get. So some patients will start with surgery. Some patients will start with chemotherapy. Some patients, surgery isn't what the treatment is. For locally advanced cervical cancer, surgery actually will end up resulting in less survival. So we actually start with radiation with those cancers. Sometimes these are cancers that can be managed with hormones like progesterone, or sometimes they get targeted treatments like immunotherapies. And in all of this, and something that I think is really important that I want to make sure everybody gets, is we need to be managing symptoms of all of this as we go through. Wherever you are in your cancer diagnosis, we want to make sure we're managing your symptoms. Now, where do you start? There's so many questions and so many places of what are the good questions to ask when we're diagnosed. And I really think this is a great resource that the American Cancer Society puts out of questions to ask about your cancer. Because it's a good checklist to go through as you're asking when you've been told, when you're talking about a treatment, as you go through treatment, and when you're finished. Now, good questions in these moments are, how soon should I start treatment? Or how soon do we have to have surgery? Because sometimes there's things that need to happen before we do surgery. It's often not a day or two later, even though that's what some people want. How long am I going to be under treatment? Is it going to be 6 weeks? Is it going to be 4 months? What days do I get treatments and what days am I in recovery? What can I do to get ready for my treatments? And another important one is, what's the best way to contact you if I have concerns? Is it through your nurse? What happens in off hours if I'm having a reaction at home or something I'm concerned about? How do I get a hold of my treatment team? Those are really good questions to ask up front. Now, these are the hard ones because these are the ones I get asked every time. The questions I can't answer is, when did this all start? Because unfortunately, we're probably not going to be able to pinpoint that. Just like I can't tell you exactly how long it's been there. Or if you're going to respond to the treatment. We know that the treatments we use in frontline, whether it's surgery or chemo and radiation, are what we have the best evidence for in these situations. It's been well studied and well researched. But whether or not you are going to respond, we won't know until we try. Will it come back? I wish I had a crystal ball for this. I wish I could tell all my patients when and if their cancer would come back, or if they'll be cured, or how long they'll live. And those, unfortunately, aren't questions any of your doctors are going to have answers for, but we really, really wish we could. And those are normal questions to have. And it is okay to wonder those things, but it's important to know that, unfortunately, there isn't going to be an answer for those. It's important to know that you're not alone as you're going through this. There is a whole team of people that it's important to be a part of. This is going to be led by a gynecologic oncologist who's going to help make your treatment plan, potentially, depending on where you are, give you your chemotherapy, or you may be meeting a medical oncologist for that, or a radiation oncologist, or your oncology nurses and your navigators. And then, as we'll get to talk about today, your social workers and the people to help with the psychosocial stuff going on. A nutritionist, physical therapists for cancer rehab, financial counselors for any of the struggles that go along financially with cancer, genetics, because about 15% of gynecologic cancers are inherited. Maybe you'll be asked to be in a clinical trial. One of the trials we have going on right now in Wisconsin is actually for patients to donate a little bit of their tumor and some blood to find that blood test for cancer. So some of those may be available for you. The palliative care and symptom management team, and then your family and friends. There are a bunch of people here their whole job is to help you through this. So it's important to make sure you can reach out, you know how to get in touch with these people and really work with them. This is just a couple of the good web resources that I can mention. Obviously, I come from Wisconsin, and so with the Wisconsin Ovarian Cancer, with WOCA, does fabulous things for my patients in Wisconsin, but also has great information for any cancer patient. The Foundation for Women's Cancer, our Society of GYN Oncology, cancer.gov, cancer.org, but also, again, the Teal Societies and Women to Women. There's so many great organizations for GYN cancers. And then hashtags if you want to follow something on social media. Okay, the GYN CSM, which is the Gynecologic Cancer Social Medias, they do a lot of things on there. So you can search some of these hashtags and get some good information. Use your cancer as a hashtag. You may find some resources and people to connect with that have had your cancers before. So this is just the beginning of your journey. It's a long road, but know that we're all here to help. Okay, and that's the biggest thing I can tell.
Thank you so much, Dr. Stevens. That was fabulous. Really such important information. You saw Ashley and I apologize. I said to everyone, we're saying in terms of timing, no, let her talk whatever she has to say. These are pearls of wisdom.
I'm so bad when it comes to 7 minutes.
You did great.
We're all bad with the timing. It was perfect.
I think one thing you said, I think that was really important. You used the word empowered in the beginning. And I think that part of the goal of the entire session is to empower listeners and to empower participants, because knowledge is power in this situation. And I think what Dr. Stevens gave you is some really important tools to communicate with your medical team, tools to do some research from reliable sources on your own, tools to be able to have conversations, with folks about your diagnosis, and to really understand what's going on in your body. And I love that you use that word empowered. So you're like part social worker. that was great. So speaking of social worker, our next speaker is my colleague from Mount Sinai. So Emily Szafara is a gynecologic oncology social worker at the Mount Sinai Downtown Cancer Centers. Before transferring to Mount Sinai Downtown, Emily was a clinical intern at Mount Sinai West in the outpatient hematology and oncology unit. She received her BA in psychology from Temple University, and most recently went on to complete her Master of Social Work from the Columbia University School of Social Work. During her time in Mount Sinai West, Emily co-authored a successful grant application to the New York State Department of Health Comprehensive Cancer Control Program that was used towards the design and execution of 3 culturally tailored workshops, highlighting the importance of cancer clinical trials for Mount Sinai Health Network patients. Emily has also recently been credited as a co-author in her first publication for the Oncology Issues Journal, focused on the importance of integrating spiritual care in the outpatient oncology setting. Emily, thank you so much for being here. We are really excited for you to follow up on what Dr. Stevens shared with us, and we appreciate your time.
Yes, thank you so much for having me. That was a tough act to follow, but I'm going to try. So hello, everyone. As Rachel said, my name is Emily Szafara, and I'm an oncology social worker at Mount Sinai Downtown. So I work primarily with GYN cancers, and I work very closely with the Woman to Woman program. So I'm very thankful to be here and speaking with you all today. The news of a new diagnosis can be a lot, to say the least. Nobody goes into this thinking that cancer is going to be the end result. Maybe it's a cough or pain or, something that you think is common. So you go to the doctor, exhaustion, anything. So hearing, that you have this diagnosis can be very shocking and overwhelming. And many people that, I work with, they describe it very much like a trauma where you are meeting with the doctor, maybe you hear one word or a few words, kind of what's going on, but you forget the rest and feel in somewhat of a dazed or confused state when you're presented with all this new information and this new diagnosis. And when you hear the word cancer, it's really hard to think about who you are and how you take this huge new piece of information and kind of integrate it into your life and your identity. But it's important to note and to point out that this is completely 100% normal. And when a person is newly diagnosed, it seems everyone is focused, rightfully so, on that person's physical well-being, whether it be, treatments, side effects. There's a lot of doctor's visits and tests, like Dr. Stevens was pointing out, that need to be put into place and done. And I call this the problem-solving mode. But I know as a social worker, and your medical team knows, and I'm sure you all know as new patients, that there are so many other parts of life that are affected by cancer. This is your emotions, your self-image, relationships with work, family, friendships. So your overall approach to life drastically changes after you hear those words. Something we often hear about is the adjustment process that comes with a new diagnosis. And this process is very different for everyone. And it's often the case that, once treatments start and people begin to organize themselves around what needs to happen, things can become a little bit more of a pattern, schedule, you get into a flow. And in time, this becomes what patients describe as their new normal. And your social worker, your medical team, amazing programs like Woman to Woman or TEAL and other nonprofits, they're here to help you curate your new version of that new normal. And it's our goal to get you to this place where you have the strategies and the tools and the coping mechanisms to have a very fulfilling life with your cancer, but that adjustment happens over time. And in my experience, there are kind of two sides to this new normal. There's the external and there's the internal. So the external includes your relationships. That can be with family, friends, community. It also includes your environments. So whether that be work or school or home, it's different for everyone. But it also involves your daily schedule of activities, what you used to do before you found out about your diagnosis. And then on the opposite side, there's this internal. And this is, typically your emotions, your thoughts. And I'll speak a little bit more about that in a minute. But first, I want to touch on the external, because in my experience, what I find often is that after the shock of hearing, I have cancer wears off, this is the first stop for a lot of patients and families, because this is where a lot of concrete planning comes into play. So, we're preparing, we're putting certain things in place, whether it be insurance, transportation to get to where we need to be. There's financial assistance resources, different supports to plan for what comes next, whether it be surgery, treatment, follow-ups, anything like that. And this brings up a really big question, and that is, where are my supports and what supports am I maybe lacking and that I need at this moment? And the first place most people turn, is friends or family, right? So you begin to think about, who will I tell my diagnosis to? Who am I comfortable sharing things with? And also, once you determine that, what do you tell them? How much do you share? And your social workers, like me, are here to really help you facilitate those discussions in a way that you're most comfortable with. And there are also really great resources out there, videos on how to do this online. One resource that I like to point out is the American Cancer Society on cancer.org, or Livestrong as well has resources. But those are just a few, aside from your social worker, to help with those discussions. This part of the adjustment process also, includes your external environment, so your schedule, maybe it's work, school, home. So you begin to think, will I take some time off of work, or who can I turn towards for support. You know, will I work remotely, part-time? Maybe you're thinking, how do I have those conversations with my boss or my coworkers? And really, what can I realistically show up for at this point in my life when I'm navigating this whole new experience, physically and emotionally, right? And social work is here to help with those conversations as well. There's one amazing resource that I tell all my patients about called Cancer and Careers. You know, they have workshops and resources for working throughout treatment, as well as getting back to work after treatment and how to navigate that process. They also have resources on having those conversations with your boss, your coworkers, as well as help with resumes, cover letters, job searching, legal help is a big one, and so much more. So they're just an all-around great resource to know about. So that's just a little bit of a lot of the big topics that come up on the external side for patients that I interact with. But also, you know, to touch on the other side of the spectrum, we have this internal side of the new normal, right? So the thoughts and emotions, and one thing I often tell patients is that in order to create this new normal internally, we must first normalize how we're feeling inside. And one of the most beneficial ways to do this is to really lean into your emotions the best that you can. Try to be aware of them as they're happening, and also being open and honest about what you need from, you know, not just your supports around you, but your medical team, because, you know, from start to finish, this process is truly all about you and you getting the care and support that you need through this. So being aware of those emotions is really a critical step in the therapy process of cognitive behavioral therapy, CBT. And so just, you know, trying your best to recognize your emotions, being aware of them as they're occurring, and practicing to reframe those thoughts in a more effective and helpful way. And that's what social work's here to help you do. So let yourself feel however you want to feel. For some people, you know, certain stages of the diagnosis can bring up many emotions at once. That can be very difficult to deal with. You know, for others, it may not, and that's okay too. You know, everyone's process is different. So whatever you're feeling, whenever you're feeling it, do not feel guilty for that. Just use your support systems to help you through whatever you need. And whenever you're feeling down, count on your friends, family, your social worker to give you the support that you need at that moment. So I'll just end with a few, you know, small tidbits, pieces of advice. The biggest piece of advice I can give you is that no question is a stupid question. I loved what Dr. Stevens shared about the list of questions. It was great. You know, ask as many questions as you want or need. And, you know, if you still don't understand, ask again, because, you know, making sure that you know what's going on and that you're comfortable with what's going on is a critical component of your care and getting through this. And secondly, I would say, you know, make sure you know who your social worker is. I'm a big advocate for social work, obviously. Make sure, you know, you ask to meet them, you have their contact information, you share it with anybody that you want or you need. Because even if you do have support and you feel as though you may not need your social worker at that moment, you know, our entire purpose really is to be there to help you and support you, just like the rest of your medical team. And we really do truly want to help you and support you, help you feel comfortable and connected with the resources that you need at any point within your diagnosis and treatment. So, you know, Woman to Woman is just one amazing resource. You know, I'm sure Rachel can attest to that. You know, she's a social worker herself, and, you know, social work has a wealth of knowledge, whether it be for emotional or concrete needs, you know, the internal or the external sides. And even if we don't know the answers, we're trained to figure them out for you and navigate the system. So, you know, just reach out to us, know who your social worker is. And yeah, that's pretty much it. But thank you so much for listening to my little speech, but I welcome any questions or, you know, comments in the Q&A at the end. So thank you all.
Thank you so much, Emily. That was wonderful. A perfect follow-up to what Dr. Stevens started. I love the way you were talking about kind of the internal versus the external, because I think that everybody can probably relate to that. You know, also what you put out to the rest of the world, you know, how are you doing? Fine, I'm doing fine. We're inside, you may not be feeling fine. And I think also your tidbits of advice at the end, no question is a stupid question. There's no bad question. Just keep on asking those questions. That seems to be a theme here. Going back to kind of feeling empowered to ask those questions, having the knowledge and knowing who to ask. I love the fact that you said, you really described the role of social work, and hopefully everybody on here has a way to access a social worker, whether it's through your medical center, through the medical team, and if not, through a community organization. But yes, go social work. As a fellow social worker, I completely agree with that. And the goal of social workers is to help navigate this very challenging situation. So you did a fantastic job. So thank you so much. Our last speaker before we get to questions is Heather Glazer. So Heather is from Connecticut and she is 53 years old. A year and a half ago, she moved to West Wardsboro, Vermont. Heather's been married for 29 years and has 2 kids, aged 20 and 19. She was diagnosed with ovarian cancer in October of 2010 and has been cancer-free for 11 years. Wow. And she is on the board of Discovery to Cure, where Ruth Ann is at Yale in New Haven. So Heather, thank you so much for agreeing to speak to everybody and to share your personal experience. And just don't forget to unmute yourself before you talk. You are muted again, Heather. I think you briefly unmuted. There you go.
Okay.
Yes,
I'm
perfect.
Good. Okay, thank you for having me. I will, I guess, go through my story. So in 2009, I had a regular physical exam, and my regular physician, she also did my pap smear, and she felt something near my ovary. So she had me do an ultrasound, and then I did an MRI, and then I was referred to a gynecologist who at that time had told me you could get a hysterectomy if you want one, but it's not, an emergency, or you don't need to have one like right away or whatever. And I had 2 young kids and working full time. So I kind of put it off a little bit. And then, and I wanted to get a second opinion. So at that point, I heard that there was a hospital near where I worked that did it laparoscopically. I made an appointment for an opinion. And when I went in, I ended up seeing a gynecologist oncologist, which she was kind of surprised they had me see her. But she did an exam and said, well, I'm going to have you do an ultrasound again. If everything's the same, I'll just refer you to someone else. But if, things have developed, then we need to have further conversation. So the day that I had my ultrasound, she called me that evening and said, okay, I scheduled your surgery for next week. I'm concerned that there was a growth and it could be cancerous. And I know you have small kids. So if you need to put it off a week or 2, that's fine. But your surgery is my last surgery because I'm about ready to give birth. So I went and I was like, no, I'll figure it out. I have a very supportive husband, family, friends, everyone like rallied around me. I went in, I had the surgery. And after the surgery, found out after they sent out to pathology that I did have ovarian cancer. I was at early stage. So I ended up doing 6 rounds of chemotherapy. I did the traditional carbotaxel. And then after that, after the chemotherapy, I had a CAT scan, and it's been 11 years since my oncologist had released me at my 10-year mark. And then I did move to Vermont, and I would feel very fortunate that I found a great gynecologist here, because I just met with her in January. And even though I'm out of the oncologist, she and I have decided to still continue with the CA 125 so I can get a yearly reading. So even though I'm 11 years out, you always have that in the back of your mind. I think that's very normal for you to be thinking about that. So I'm very grateful that I have found someone that would, continue doing that test for me. And at the time going through the cancer, I just tried to make my life as normal as I possibly can. My kids were 8 and 10 years old. So I felt like more so for me, but for my kids, to make their lives as normal as possible. I remember sitting in my first chemo treatment, And the school psychologist called me and said, I just met with your daughter. And beforehand, I had emailed the principal, explained everything that was going on. We had a very small, supportive school. And she said, I would like to meet with her once a week if I give you permission, if you give permission, just because, you know, she's got some questions and other things, and some fears that maybe she wouldn't say to you because she's concerned about you being sick right now. So I thought that that was a great resource. And if there are other people going through it with little kids too, the American Cancer Society was also a great resource because they came and met with me and gave me like coloring books for the kids and kind of talked to me about how to talk to them. Because honestly, you know, it was a very scary time. I always felt like I would be okay, but, you know, I did lose all my hair. And, you know, when you say cancer to kids, they might not understand that, but the physical aspect they can see. So that was something that that was helpful to me during that time. And then in the years that followed, you know, working with Discovery to Cure now, I really like to give back. I feel that I was extremely fortunate that my cancer was found early. And a lot of people say, oh, you were so young to have ovarian cancer. And I'd like to let people know that there's not like an age limit on ovarian cancer, and it can happen at any age. So I think that's really important. I met a person who was going through ovarian cancer when she was 8 years old. So I think it's just important to know that it doesn't only happen to older women. And just really like to try to give back. And, you know, I'm open to talking to anyone who has any questions. You know, the chemotherapy for me, I felt like it was way worse in my head than when I actually had it. So I think it's the, you know, unknown. When you're going through the cancer, you may think of things in your head like, oh, or what it's going to be like. But for me, I didn't have that many side effects other than losing my hair. So I felt like I was extremely lucky. And I'm open to anyone who has any questions.
Thank you so much, Heather, for sharing your experience. I think you make a really interesting point that, you know, this can affect women at any age. And I think that, you know, people might have a preconceived notion of ovarian cancer as just older women, you know, in their 60s or 70s, but to hear that you interacted with someone who was 8 years old, I mean, is obviously very unusual, but you know that those statistics are out there, and so it's great to share that. And thank you for sharing those resources related to your kids. Also, people are at all stages of life when they're diagnosed, and whether it's your children or even your grandchildren, if you are older, you make that really important point that you can say, okay, I'm going to be okay. You can kind of say whatever words you want, but kids notice the appearance and they notice about the hair. They notice if you look tired. They notice if you have bags under your eyes, you know, that type of thing. And they comment on that. I have 2 young kids myself, and boy, they comment on everything. So if I don't get a good night's sleep, you look tired, you look awful. So I can relate. So now is our time for questions and answers. You are welcome to put anything in the chat. If you, you know, again, you can use the hand raising feature. Ashley and Ruthann will both be monitoring for questions. Maybe I'll just jump in and get us started here. And maybe this would be a question and I can kind of help field it. What would be the one piece of advice that you all would give to somebody who is newly diagnosed? The one piece of advice that you have for them if they take away something from this? And this would be for all 3 of you. I'd love to hear your separate answers. So maybe Dr. Stevens, we'll start with you.
So I would say the biggest thing is, as women, we do a very bad job of asking for help. We are the caregivers. We like to take care of everybody around us, and we are not used to asking for help. And I think what I got from both Emily and Heather as they were talking is you need to be able to say, this is what I need, and I need you to do it for me, with me, along with me, but really be able to feel comfortable asking for help, whether that's from your partners, whether that's from your children or your grandchildren or your friends, or whether if you have no one as a support system, know that that's what we're all here for with social work and your physicians and your nurses. This is what we love doing, is taking care of our patients. You're never a bother. Okay.
Yeah, I mean, I completely agree. I think, you know, I said my little tidbits of advice at the end, but just to reiterate them, you know, ask your questions, know your social worker. I know, you know, being newly diagnosed, it can be so much information at once. You know, you are getting medical terms and you're meeting so many people, and sometimes you just want some time to be by yourself and kind of process this, or you just want to talk to the people that you know and that you trust. But just, you know, try and take it in the best that you can, and, you know, save those business cards, put them in a baggie somewhere that you know where they're at, so that when you need them and if you need them, you have them handy. And yeah, I mean, just do the best you can, because, you know, and if you need help, we're here for you.
I think for me, a piece of advice that my oncologist actually had given me, one, I felt like it was always best to have a positive outlook on my diagnosis. But second, my oncologist said, don't go on the internet and torture yourself. She said, if you have questions, bring questions to us, bring questions to the nurses, but don't torture yourself on something you may read on the internet.
I have a couple questions coming in, Rachel, also, if you'd like me to.
Sure, that sounds great. And I think also, Heather, that was great advice. And it goes back to Dr. Stevens, the list of kind of reliable sources. And I think your point is very good. Do not get information by Googling things and just seeing what pops up. Go to those reliable sources that Dr. Stevens pointed out. And again, we will be circulating this information afterwards, this talk, including the slides. So you will be able to go back to that. And each of the separate organizations will get a copy of the video to put on their websites or whatever they'd like. So this information will be available to people. But all three of those pieces of advice were great. So Ashley, let's hear the questions.
First, for Dr. Stevens, are you seeing an uptick in ovarian cancer diagnosis recently, say in the last year or recent 6 months?
So interestingly, actually, the projected statistic for ovarian cancer for 2022 is a decline. And I don't know how those numbers come about, because again, we don't have crystal balls. We like to try to predict what it is. So I don't know if they're predicting less because there were less cases last year, or whether we're actually going to end up seeing more because people not getting diagnosed. But ovarian cancer patients often have 4 to 6 months of symptoms before they get diagnosed. And so they tend to bounce around the medical system anyhow. It's generally stayed pretty stagnant around about 22 to 24,000 diagnoses each year in the United States. They're projecting around 20 this year. So I'll be interested to see where that kind of falls out as the year goes on.
One more question here. Why do you use a CAT scan, not a PET scan, for uterine and endometrial cancers?
So as I was mentioning, PET scans are really good and sensitive for tumors that are rapidly growing, okay? Because cancer cells that are rapidly growing light up on a PET scan. Uterine cancer most commonly is diagnosed as a grade 1 cancer, which is a low grade or a slow growing cancer. And because of this, the PET scan doesn't give us any additional information and often can be falsely reassuring. We could see areas that are concerning that don't light up on PET scan, but actually have cancer in them, often in the lymph nodes in those situations. So a PET scan doesn't have the same predictive value with uterine cancer and isn't as helpful. That even goes with ovarian cancer sometimes. Ovarian cancer, we often deal with like sandpaper-like tumors, really, really small and fine tumors. And PET scans are really only effective at picking up a cancer that's more than a centimeter. So you may hear about people getting PET scans, and there's certainly roles for it, but it often isn't the first diagnostic test we use with ovarian or uterine cancers.
Okay, a couple of resources are coming in the chat, so I will include those in our email blast afterwards. And let me see here. I think there's one more question for Dr. Stevens. For your patients after they have finished initial treatments for ovarian or uterine, what protocol do you use for follow-up? Maintenance drugs or just blood work and scans?
So that's great. That is an ever evolving process right now. Ovarian cancer patients have a couple of different maintenance options depending on what treatments you got up front. If you had bevacizumab or Avastin or any of the biologics, you may continue on that for a year after treatment. You may get treatment with a PARP inhibitor as a maintenance medication, something like olaparib or niraparib, depending on your genetic testing. So for ovarian cancer patients now in frontline treatment, there is often a maintenance option if you are stage 3 or 4 at the time of diagnosis. Uterine cancer patients, it's very drugs or very tumor type specific. So as I mentioned, we're getting better at just not leaving uterine cancer as one disease anymore. There's actually really specific things. You'll hear things like endometrioid or serous or carcinosarcoma. And so we do have maintenance options for different types of uterine cancers, but the majority of uterine cancers, which are low grade, often don't have maintenance. They just have surveillance and follow-up. So it's an important question to ask your doctor about what does the treatment look like for me and why are we doing it? It's okay to ask us why. We're happy to explain it. It's important to know. And I think one of the other things I'll say is it's also really common for patients that after you go through all of this, whether it's chemo and radiation or surgery and then chemo or surgery and then radiation or all three of those things, that you sit down at some point when you've completed treatment and you go, what the heck just happened to me? I don't even know what type of cancer I had. I don't know what stage it was. I don't know. Why did I do all those things? What were we trying to do? What's my survival? It is so common to sit down with patients in those first couple of months after treatment and kind of talk to you all about it all again. And that's okay too. And that's really important. So don't feel like it's silly down the road if you're like, I don't remember what my stage was, or I don't know what type of cancer I had, because this is a lot happening all at once.
I think that also Emily used the word trauma. You know, she said that really many patients feel traumatized, and you're kind of describing that, Dr. Stevens. You know, it's almost like post-traumatic stress, you know, after you're past the initial crisis part and you can kind of breathe again, everything kind of sinks in, and that's very conducive and very consistent with, you know, people who are feeling traumatized by an experience. So it was a great.
I will add on to Dr. Stevens and kind of what Emily were talking about as far as resources and trying to find a community-based organization. Wisconsin has the Wisconsin Ovarian Cancer Alliance. A lot of states have something similar. Ovarian Cancer Research Alliance is who we are a partner member of. So on their website, they would have a list of all the ones that would be located in your state specifically. Otherwise, if you have a social worker, they should absolutely know. But we have different programs aside from the hospital that we would be able to offer. So mentorship programs. I know Clarity Foundation also has some support for finding clinical trials and things as well. But I know some community-based offer mentorship and financial support as well. So there are definitely a lot of resources, especially if you feel maybe that your support system isn't what you would want it to be. We can absolutely help with something like that. And then I also am going to put in the chat my personal email for work. So if you have any questions after this, feel free to send them to me directly and I will get the answers for you. Everybody should have had to enter their email when they logged in. So as long as you had to do that, we'll be sending a follow-up afterwards with the slides from Dr. Stevens, and then you'll be able to reach out to me as well. And then if you need help finding an organization that's close to you, I can absolutely find who would be able to help similar to WOCA if you're not in Wisconsin.
And I want to just give a push for one of our other partners here, Teal also, as Teal is a community-based organization that provides services not just in the New York area, but also I know they have a lot of patients they work with throughout the country too. So we're about at the end of our time. This was fantastic. I continue to be so impressed with the information, knowledge, and passion that you all bring. Dr. Stevens, Emily, Heather, thank you so much for sharing your experiences and doing your best to educate women who are more new to this journey. And I look around and there are some people who are not so new to this journey, who've actually been doing this for a while. And I think it was valuable information for everybody, whether you're having a recurrence, whether you're, a survivor, not in active treatment. This is really, really important information. As Ashley said, the teams that put this together want to remain a resource to all of you. So please reach out directly to Ashley with any questions, and she can direct it to the appropriate either panelist or community organization involved, to help answer and direct or connect towards resources. Thank you all for taking an hour out of your evening, out of your busy schedules to be here with us. Again, the 5 organizers today, it's WOCA, Wisconsin Ovarian Cancer Alliance. It's Discovery to Cure at Yale and New Haven. It's Clarity. It is Teal, and it is Woman to Woman at Mount Sinai. We love that we've all partnered together for this common cause, which is to empower and educate all of you. But most importantly, we are grateful to each and every one of you for being here tonight, becoming part of this supportive community, and hopefully feeling a little bit lighter with this newfound information and sense of community support that you received. So thank you all so much. I don't know, Ruth Ann, if you want to say anything quickly.
I just want to thank everyone for joining us tonight. Dr. Stevens, Emily, and Heather, thank you. It's always great to hear other people's views. We all go to different doctors and see different social workers, and it's just awesome to hear from the different areas that you're in. And thank you for that. And Heather, as you know, we're always cheering you on because you're a great story, and we want to hear everybody's 11 years, 12 years out from this disease. So thank you all for this evening and joining us tonight.
Thank you, everybody.